of Surgeons of Canada and the American Congress of Obstetricians and Gynecologists. He's the founder and namesake of Victory Reproductive Care, where he's built a world-class multidisciplinary clinic dedicated to helping individuals and couples achieve their dream of parenthood through compassionate and patient-centered care. So, without further ado, welcome Dr. Victory.
Thank you. Thank you, everybody, and I appreciate you all being here nice and early. To all the people who are insane and like to run, my apologies to all of you for the fact that they're blocking your access to getting here. So, do you guys want me to start with just answering questions to see if anyone else comes in, or do you want me to just jump into the presentation? Because I'm good either way. Do the presentation? Yeah? Okay. All right. I'll start with the Prezi, and if you... I'm very open to making this completely interactive. It's a small crowd, so if you have questions, just throw up your hands and I'm happy to jump into any questions that you have, okay? So thank you for that wonderful introduction, Marissa. My office put all this nonsense in there, so here's really me. You don't need to read all the other stuff. So I really love infertility. I'm very passionate about infertility, and in particular endometriosis, which is an area we sort of focus or specialize in. I am a huge advocate for being transparent and for being truthful. I find that in the infertility industry, as it becomes kind of more and more bought up by venture capital, private equity, becomes business driven, we're getting less and less transparency. We're getting a lot of money driven decisions, financially driven decisions, and people are kind of herded into what I refer to as the IVF grinder, which is basically you walk through the door, they're calculating, literally there's actually a calculation called a conversion rate, whether or not you're going to become an IVF patient. And then if you're an IVF patient, they kind of throw you in as fast as possible. Maybe you get some information, maybe you don't. You come out the other side, generally speaking, fairly wounded, even when it works. And so I think we need to change that dynamic. There's a lot of good we can do with the infertility treatments we have, and there's actually a lot of harm we can do. So it's important we be honest and truthful. I'm never really satisfied till we reach 100%. So we have a standing joke in our lab where when they actually get 100% fertilization, they say, what more do you want? And I say, well, 110, but that's actually not physically possible. And so we really try hard to optimize all the time and go above and beyond. So the first 3 months of this year, our success rates were over 90% per month, like overall. And so that's probably the first time in a long time I was actually like, yeah, now we're good. I was really pleased with that. So that's an acceptable rate as far as we're concerned. And I don't think everybody needs IVF, so I don't measure conversion rates. I never will. I think it's disgusting we even look at that. I'm a big believer that patients should get a very holistic approach to things, that we should really address all of the patient's concerns, and that in many instances, IVF is not necessary. And we have all sorts of tests and treatments that we offer to patients where they don't end up needing IVF. Patients should be educated. They should be informed. I should be there to be the sounding board for their concerns, their understanding, their education, and then you should be making the decisions. No one should be pushing you into treatment. You should decide what's right for you, because I'm not in your shoes, and I probably never could be. And so it's really important that you make a decision that's informed. So we're going to kind of touch on these broad topics, epidemiology, AI use in infertility, which is really becoming a big thing, in vitro gametogenesis, IVM and low-dose protocols. IVM is in vitro maturation, advancements in holistic care, mitochondrial replacement, which I'll spend a little bit of time on, a little bit on robots, and then I'm going to throw in some interesting slides in there for you all too, and where we are, at least for our clinic, in terms of how we're positioning things and how we treat people. So it's really important to establish the baseline, which is kind of horrifying. So Tariq Ibrahim, my social media guru and very close friend, who's sitting up in the front here, and I talked to ChatGPT one night when we were preparing for a live show we do every week. And I said, can you forecast what's going to happen with fertility rates going down. And I think he's working on the video, so it should be out soon, but it's actually quite terrifying. So essentially, we are headed towards a very not good global situation. So to kind of give you the stats, the total fertility rate has dropped from a point in history where we were having a lot of babies, like 4 or 5 kids per family, down to 1.7 in 2100 is the estimate. However, if you look at large cities, something like London, England, the fertility rate in London, England is 0.4. In order to understand this better, the population replacement rate, so just to keep the population even, is 2.1. So we are at less than a quarter of what's necessary just to maintain the population. As the population shrinks, you lose your tax base, which means the government can't function, and then you run into global economic, basically, disaster. So are we headed there? Yeah, we actually are headed there. It's going to be a long way away, but it is coming. And so infertility is a really very, very significant problem. When I talk to anyone in the financial world, I tell them the best investment anybody can make is in infertility right now, because it is just going to continue growing and growing and growing. So right now, we have a projection that by 2050, 50% of the world's countries will be below their population replacement rate, and by 2100, only 3% of the countries in the world will be able to meet their population replacement rate. And all of those countries are actually in Africa. So the rest of the world is in for a real wake-up. And I think they're kind of picking up on it now because governments are pouring in money. God bless the government of Ontario, and I'm completely apolitical, but they actually are investing into fertility care. They've committed to $150 million over this year and next year for more IVF expanded coverage. And so they really are making an effort to change it. And globally, that's what's happening. There are cities in China that will pay women $40,000 US per year just to have a baby. So this is really up and coming and very prevalent. So the key drivers for this, the obviously critical increase in female education. It means more women are entering the workforce. There's less desire or drive to be at home. It doesn't help that with costs and inflation and everything else going on, many of us have to have 2 people working, whether it's the male or the female. Contraceptive access is pretty much universal. Urbanization has reduced the growth rate, and obviously the economic standards and what we're all facing on a daily basis have a role as well. Delayed marriage is taking a toll, as well as childbearing, obviously. And then, of course, more women in the workforce means there's less people at home having babies. I'm not against that. I want to say that categorically. I think it's wonderful that women are in the workforce, but it is one of the drivers for why we're having less babies. Environmental factors, we probably couldn't have a more toxic world if we tried, although I know people are trying. So that's a huge factor as well. We know that there are endocrine disruptors that can completely sort of disturb and distort your metabolic function, your hormonal function, and these have real consequences for your health and for your fertility. In men, there are huge changes in infertility. We have decreased sperm counts, decreased testosterone levels, increases in testicular cancer, and real biological disorders that are leading more and more to male fertility problems. As I said, the global burden is very significant for this, and it's projected to continue getting worse. Male infertility in particular is very crucial because the estimate right now is that by 2050, 50% of men will be infertile, or at least fall below the international standards for what's considered normal or abnormal sperm. So we really are facing a crisis with the men. And it used to be that infertility was treated kind of primarily as a female-oriented issue. It very much is going to be primarily male-oriented very soon. And even now in my practice, I see that on a day-to-day basis. It's actually fairly rare that we see guys that have normal sperm these days. Emerging solutions, well, that's where we come in. So obviously there's new strategies to combat infertility, new technologies that are being employed. There's constantly research going on in these areas. And so people are trying more and more to find creative solutions, innovative solutions to solving a lot of the problems that we have, male factor and female factor. Let's talk a little bit about the use of AI, because that seems to be the growing trend these days. Everything is AI. How many of you have used ChatGPT? I'm just curious. Yeah, pretty much everybody, right? Yeah. I love chat. I got my chat to speak to us, and she has this really lovely voice. So when Tarek and I did the talk, she was talking to us. It was really quite neat, but what she was telling us was horrifying. So it was a very interesting experience. So artificial intelligence is rapidly transforming every field, and infertility is one of those fields as well. It's being used in pretty much every aspect of what we do: sperm assessments, egg assessments, embryo assessments, quality initiatives, workflow optimization, you name it, it's involved everywhere you can see it. So one of the main areas is sperm quality. We're looking at sort of AI-based models that are attached to a microscope, which can actually track the motion of the sperm, the shape of the sperm. It kind of creates a halo ring on a screen that says that's the sperm you should use, and the embryologist can then go and pick that sperm when they're doing ICSI. And it will hopefully increase the rates of success. Now, right now it's getting the same success rate as a top-notch embryologist. So it is very advanced. We haven't taken it beyond what a top-notch embryologist can do, but that's probably just a matter of time as these algorithms get better and the science and the data that's fed into it improves. You can analyze sperm shape, the motility. They're even looking at the DNA integrity of the sperm with higher accuracy than we get when we hire someone to do this job on their own. There are multiple tests that are now available. I've listed some of them there: the SID, the sperm Q. There's a sperm T now, I think, or QT as well. Many different tests that are available, and all of these tests are becoming commercially available so that you can kind of send your sperm sample into a facility or an agency or whatever the case is, a lab, and they will send you a very nice detailed report saying, here's what's wrong with your sperm, here's how you improve it, fire away. And it's designed to actually improve your success rates or to predict how good your success rates are going to be. In terms of predictive algorithms, this is up and coming as well. And I'll show you something at the end of this slideshow, which hopefully will blow everybody's mind because it's very powerful. AI is really taking a dominant role in being able to help you determine, am I going to be successful? And that's going to be really important for us in the future. Preventative strategies are probably up and coming. There's not a lot on it out there right now. Preventing infertility in guys is relatively easy. Don't smoke, don't drink, don't do drugs, exercise, keep your weight down, eat a healthy diet, avoid cell phone and electromagnetic radiation exposure to your testes, and keep them cold. So we tell all of our patients who have male factor to sit on frozen peas for 20 to 30 minutes a day. And definitely have frequent intercourse, that's important as well. Deep learning models are coming out for embryo grading, blastocyst selection, and implantation prediction. So you can actually feed images of your embryos to an AI software system. And the software system will measure various aspects of the images, spit out a result and say, here's your chance of this embryo becoming a baby, and actually here's the chance that this embryo is genetically normal. So the images shown here are from a company called Life Whisperer. I have nothing to do with this company at all, but we use their technology. You literally just feed it images so you don't have to touch the embryo at all. And then it can actually determine statistically what the chances are that that embryo will A, become a baby, and B, be genetically normal. Is it diagnostic? No. So that's critical for everyone to know. So if you're thinking, why don't I do this and save myself a lot of money instead of doing PGT? PGT is diagnostic. This is not diagnostic. This is purely just giving you the suggestion or the statistical chance that the embryos are good or not. It's mainly determined to allow you to rank your embryos. So if you have, God willing, 10 embryos sitting there and you want to decide which one to use first, this technology will tell you this one has the highest chance of success, this one's next, and so on. But it's not designed to say, don't use this one versus use that one instead. So this is really important because more and more of these strategies are becoming available, and they're refining them constantly to make them better and better. So as an example, when you use this particular system, Life Whisperer, they break it down into 4 categories. So you have your very low, medium, and high, or low, medium, high, very high. Those are their 4 categories. And if you have 2 embryos in their very high category for genetics, there is a 97% chance that one of the 2 embryos is actually genetically normal. So that's actually pretty good. Not quite diagnostic, but we're getting there. And so as they refine this technology, we're going to see better and better outcomes and better prediction models. I don't know if any of you are watch fans. This is probably one of the most expensive wristwatches in the world. They are finding ways to predict the outcomes even before you start. So if you haven't heard of epigenetics, epigenetics are slight modifications to DNA, whether it's attachments of sugars and proteins or histones and all these chemicals that modify the way that the DNA functions even after you've had your genetic code established. And so epigenetic changes are actually critical to outcomes. And scientists are now using AI to actually be able to look at epigenetic changes and then predict how you're going to do. So in this particular research project, they created what they called an epigenetic clock, which meant they analyzed changes to the DNA methylation and sugar add-ons and histones, and they were able to say your DNA looked like it was this old, regardless of what your actual biological age is. So you actually have your biological age, you're an average of 30 whatever, and then you have your DNA age, which might be younger if you're really healthy, or it could actually be much worse and older if you're not that healthy. And they can actually use this technology and this information to then tell you how well you are going to do in your IVF cycle. You can actually predict the outcome of your cycle before you begin, just based on these tests and assessments of your DNA and what's stuck to your DNA. So this is the next phase in where this technology is taking us. Basically being able to tell people in advance, here are your chances. So that transparency again, which is really important for me, this is where it's headed. We're going to be able to sit you down and say, Jack, Jill, you have X% chance that this IVF cycle is going to work for you. That watch, by the way, is about $500,000, so it's completely crazy. We're looking at testing as well now that can determine whether or not there are other things that are going on in your system. So we're looking at things like the microbiome, and AI is being used in that regard. There's new technology. It's not necessarily just AI. We're testing of the microbiome using advanced genetic testing can tell you what bacteria are present in your uterus and which ones are not. So have any of you had an endometrial biopsy done? 1, 2, 3, yeah, several, 4. So most horrible experience of most women's lives. It's extremely painful. It's not comfortable at all. And I'm very horrified to tell you all, it's a completely useless test. So if you actually put 10 pathologists in a room and show them the exact same picture of the results of your endometrial biopsy, you will probably get 11 different answers because one of them can't even decide between whether it's normal or not. So it is a useless test. When you look at inter-observer variability, which is the amount of times that the pathologist will agree, it is exactly the same as flipping a coin. So this type of technology requires menstrual blood or a swab and can tell you with zero pain whether or not you have normal bacteria or not. Is the microbiome important? It's hugely important. There are many studies now confirming the fact that if you have an adverse microbiome, that it actually will severely compromise your chances of success. So Fertility, which has a booth here, and again, I have no financial involvement with them, is one of the companies that kind of pioneered this technology, and they're quite famous, and we talk about them all the time because I love them. But they do a great job of analyzing the microbiome. There are other companies as well that can be used, at least one of them I've seen here today. And so you can use this technology, leverage this to tell you, is your uterus ready from a microbiome standpoint for the implantation of your embryo? For those of you that are going through stimulation, especially if you're a relatively high egg producer or you get a high estrogen level, note that research is showing that that high estrogen level actually directly disturbs your microbiome. So if you've ever had a cycle where you made 15, 20 eggs and they're encouraging you to do a fresh embryo transfer, hit the brakes, because your microbiome is not ready for that embryo to implant. And this research is actually showing that very clearly, demonstrating that women who had high estrogen levels actually had a predominance of adverse bacteria, and that those adverse bacteria will prevent you from actually being successful. Gametogenesis. How many people heard that somebody turned skin cells into eggs recently? Yeah, well, a few people out there, yeah. So I was like, wow, this is really advanced technology. So this is very, very cool, where scientists are now working on the ability to create sperm and eggs basically from cells that have nothing to do with sperm and eggs whatsoever. So this is the holy grail, because we have men that have no sperm or very poor quality sperm, and we have many women that are suffering either from diminished ovarian reserve, or they have problems with their egg quality. And so can we actually generate eggs for them, generate sperm for them, and see if that can work? On a whole other level, we have same-sex couples, and they want their genetics to both be in the child, and this kind of technology would actually potentially permit for that. So the programming for this is extremely sophisticated. Essentially, you can take ordinary cells in the body, and I'll show you a schematic in a minute, and they reprogram them to basically behave like stem cells. They then kind of differentiate those stem cells to become egg or sperm cells, and then they mature them, and then they use them. So I'll give you a little graphic so that you can look at this and see what this looks like. So the first one here is just a skin cell. And this skin cell is basically scraped off or biopsied or taken, and they kind of isolate the skin cells and make sure it's in a sterile environment and so on. So you then take the nucleus, which is where all the genetic material is, from that skin cell, and you plug it into an empty egg. The sperm part's a little bit more complicated, but this is what they're doing for the eggs. So once it's in the egg, you then go full Frankenstein and you electrocute the egg, okay? So you electrocute the egg, which tells it to discard half of its DNA. Because you gotta remember that normal cells have 46 chromosomes, but eggs and sperm only have 23. So that when you match it with the other gamete, you get a normal cell with 46 again. So you gotta get rid of half the DNA, and that electric shock and some chemical treatments actually facilitates that process. Now, the one dilemma is that getting to the point where you actually have a balanced number of appropriate chromosomes right now is extraordinarily inefficient. So in less than 9% of cases were they able to get it to have sort of chromosome 1 through 23. So we all have 22 numbered chromosomes and then an X or a Y. So they're only getting it to that point where you have 1, 2, 3, 4, 5, straight through to 22, and then the X and Y in less than 9% of cases. So it is very inefficient to do this. However, when they are able to eventually achieve a balanced gamete, you can then inject it with sperm and it'll fertilize. And they've actually done it successfully now. So they actually took skin cells and they actually made embryos out of them. So this is the future. So for women in particular, or men who are azoospermic, who are struggling with their fertility and they can't produce any more eggs, this may be a way to restart the process. How far away are we? Probably a decade or more. It's a long way away, but there is a tremendous amount of hope for the future. So maybe by 2035, like the title of this presentation is. I want to give you all a huge warning. So I don't know if you guys have seen us on social media. We tend to do a lot of social media work. And this is a post I saw while I was on call on Thursday at the hospital. And I saw this and I was like, oh my God, look what they did. They took this old monkey and they made it a really young monkey by doing all these, tests and engineered stem cells and all this. This looks incredible, right? Like anyone looking at that is like, we can reverse aging. And there's actually research coming out of Japan where they discovered some sort of drug that they're claiming can extend your life to 250 years. I don't think we'll be moving at that point, but you might be living. So the interesting thing with all of this was, I was like, this looks phenomenal. Where's the study? Let me look at it, right? I want to reverse my aging too. Why not be 18 again? This sounds great. My wife would probably kill me, but I'd be worth the try. So this is the actual study. It's called Senescence-Resistant Human Mesenchymal Progenitor Cells Counter Aging in Primates. So excited, Dr. Victory, I'm like all in. Show me the pictures of the monkeys, right? That's the picture of the monkey. That's the actual results from this. So when you go on social media, be very wary of what you're reading and seeing, because what they're selling you is hype. It's not actual hard scientific data. Were they able to kind of change the biological clock in those monkeys? They actually were. So by injecting these progenitor stem cells, they were seeing hormonal changes, age-related changes, metabolic changes, which made these older monkeys behave like younger monkeys. But it's not going to turn you into an 18-year-old again. So the interesting thing in this study is that they actually did look at reproductive outcomes. And in these sort of menopausal monkeys, they're seeing hormones normalize. So again, there is technology on the way that will help us, but be very careful of what you read online, because you're not going to turn the old monkey into a new monkey. So currently with in vitro gametogenesis, we've seen the skin going to the eggs. We've seen sperm as well. In mice, they've actually recreated the entire sort of reproductive profile and process in vitro in the lab, and they're able to actually make eggs and even live offspring. So we've seen it in animal studies. This can actually work. Male IVG has produced spermatids, which are like kind of pre-sperm. It's one of the processes or stages in the sperm maturation. And so we're getting there, and there are functional sperm that people have used, which have also led to the development of embryos. And then there's progenitor stem cells, which you can turn into eggs as well. And that's another area that people are looking at in the near future. Applications are obvious. You can bypass age problems. You can bypass issues with sex. You can bypass all sorts of problems and create real viable, tangible solutions for people that are otherwise stuck without an option, without having to go to donor. So that's the critical element here for many, many people. What about in vitro maturation? So most of you will know, if you've ever done any kind of fertility therapy, that there's typically, but not always, some type of ovarian stimulation. So in many cases, you're using injectable medications. Those medications can be very expensive and they are complicated. Now, thankfully, they're very powerful and they help us do what we need to do, but it is complex. Not everybody responds well. And so some people need an alternative option. So in vitro maturation is the process where you take eggs that have not been stimulated by meds or minimally stimulated by meds, and you retrieve them and you mature them in the lab. There are advantages to this for two groups of people. One, women with PCOS who have a lot of eggs, and when you stimulate them, they actually make too many. In the past, before we had new triggers that we can use, The results were concerning because a lot of these women would get quite sick after you did the egg retrieval with something called ovarian hyperstimulation syndrome, which was dangerous. You can die from OHSS. Nowadays, we do better because we use triggers that don't create as much of a drama situation afterwards, and it's a lot safer. So the other group is actually potentially older women whose ovaries are uniquely deprived of oxygen the older you get. So one of the reasons that is thought to be problematic for older women is that their egg quality declines because basically the ovaries have lower oxygen tension or oxygen concentration. And as a result, the egg quality gets compromised. But if you pull the eggs out earlier and you expose them to higher concentrations of oxygen, it may actually improve the egg quality. So there is a guy out in California that has started doing this because the average age of his population is 43, which is very advanced for most fertility clinics. And so he had to find a way to help his predominantly older population of women. And so he said, I'm just going to start retrieving the eggs earlier, expose them to higher concentrations of oxygen, and then see if we get better outcomes. Now, he's published the research. It's not what I would consider super well done research, but it does look promising. The interesting thing is he stimulates his patients for several days first. So typically if you're doing IVF, you're retrieving when the follicles are around 18 millimeters, maybe 20. He's triggering as early as 12 millimeters, 12, 14, 16, in that range, depending on the patient's age. And the older the patient is, the earlier he retrieves them. So there's also concurrently technology coming out that is helping us with the process of IVM. Traditionally, IVM was not very efficient. You could retrieve the eggs, but very few of them would mature. The success rates were low. But there's new models of IVM which are actually improving these outcomes. And so when I was listening to this gentleman at a conference speak about his 12 millimeter egg retrievals, I put two and two together and we thought, what if we did this in older women but used the new technology for IVM? So in about 2 weeks, we're actually going to be starting a research protocol looking at exactly that. Can we retrieve eggs with zero stimulation in older women and then convert those into good quality embryos? And we think very much that the answer is going to be yes. So we're really excited about that. There's other applications to this as well. You can throw in chemicals into the media, you can throw in additives, nutrients, which will further facilitate the quality of the eggs. There's a company in the UK, which I'm not allowed to discuss yet because I'm in an NDA with them, but they're actually looking at the ability to alter or minimize the number of genetically abnormal embryos you produce, no matter what your age is, by actually treating immature eggs with a certain compound, which then reduces the number of genetically abnormal embryos by 95%. So we're doing research with them now, but you have to be able to mature the eggs to do it. And you can also combine this with other things like preserving the tissues from the testes or the ovaries to provide even further advancements for cancer cases or people that have to delay their fertility for a long time. Other approaches, low-dose protocols. So how many of you took more than a combined 300 units if you've already done an IVF cycle? Yeah, quite a few people. So high-dose protocols are horrible for your egg quality. Don't do them. It's actually frying all the eggs. So you want to be on a reasonable dose protocol. There's no question that the meds definitely are beneficial. They will help your cycle, they'll help you make more eggs. But if you use too much, it's actually damaging to egg quality. So there's a lot of research going into using lower dose protocols. This is great for women who are suffering from diminished ovarian reserve. If you're only going to make 2 eggs or 3 eggs, whether you take 450 or 600 units, or you take 150 units, you're still only going to make 2 or 3 eggs. So why go through all the extra medications, the extra cost, the hassle? And it's damaging, as I mentioned. You want to reduce risks, you want to reduce costs. We want to maintain the same outcomes. Per cycle, if you look at lower dose stims, you will get a lower rate of embryo development and sometimes success, but overall, cumulatively, it's got the same outcome. So for some women, they'll respond better to this approach. It's not for everybody, but it is an option. Individualized approaches, which I'll talk about in a little bit, you want to tailor based on the patient's age, their BMI, their ovarian reserve, and their history. And minimal stimulation may be better for poor responders because in that group, when you give them high doses, there are even sort of more significant adverse changes to the egg quality. In terms of innovative protocols, there's progesterone priming. So most people have heard of Cetrotide or Orgalutran. These are great products that we use to prevent you from releasing your eggs. You can actually do the same thing by just giving patients progesterone. I'm not a believer yet because I don't think the research is there, but there is a lot of research coming out on this, and it's showing that it's probably equivalent in terms of outcomes. So this may be the future because, again, it'll save on costs. You can reduce premature LH surges. You definitely reduce your OHSS risk. And again, we're hoping to develop the same outcomes in terms of quality, quantity, success. Holistic care, I think, is really important. So you'll see lots of nutrition therapies here, psychological assistance, there's coaches out there, and all of these are actually really important. So addressing your physical, emotional, psychological needs is critical. There's no question that these are significant factors as part of your fertility journey, and it does impact your outcomes. So you will do better the more emotionally, psychologically well you feel. Stress can have a huge negative impact on your success, as high as 60% reduction in your outcomes. So this is really important. And nutrition is really important as well. Your antioxidants, your vitamins, your omega-3s, your glycemic indexes in terms of having low carbs and as well low cholesterol, low fats. These are all really important. Precision nutrition actually uses things like genetics, metabolics, to actually determine what you need, as well as the microbiome, so that you can figure how to adjust specifically for you what is necessary for you. And there are various people in the nutrition world and in the supplement world and so on that have figured this out and really nailed it down. The Mediterranean diet is consistently linked to improved fertility outcomes precisely because it actually improves your metabolics and it improves your microbiome. So all of that has an impact on your nutrition, your well-being, your hormone levels, and so on. Now, I wasn't a huge believer in this nutrition sort of theory until Tarek and I interviewed a lady last week, and she's a nutritionist, the fertility nut, and she said, what you feel emotionally actually impacts your digestion. So when we're doing podcasts, obviously I need to maintain decorum, and so I had to keep a straight face, but in my head I was thinking there is no way that this can be true. But it actually is true. Your emotional state regulates how you absorb what you eat. So if you're already stressed, if you are not happy with your doctor or your clinic or your partner or your existing children or your financial well-being or whatever it is, and you're stress eating, you're actually directly negatively impacting how you're absorbing the nutrition that you're taking in. So even if you're eating a super clean diet, but you're stressed out of your mind, it's not working for you. And I absolutely was flabbergasted. Tarek and I were kind of chuckling after the show, but like, it's true. There's lots of research. This was just one paper that I looked at, which shows that you actually can alter the leakiness of your gut just by being stressed. And so you won't absorb the nutrition properly. It'll alter the microbiome as well, so you have more adverse bacteria. And again, that alters how you respond to things, how your hormones function. Yeah?
Is it possible to reverse the unhealthy food and be relaxed?
The question is, can you reverse that and eat unhealthy foods and be relaxed? That's a great question. I hope so, because it'll help my chocolate diet. I don't know. I don't know what the answer to that is, but there are some very qualified nutritionists here who might be able to answer. I would guess the answer is no, but a healthy, balanced diet is critical to your fertility success. And so again, this holistic approach is important. I see people, we get a lot of consults as second opinions. And so I see a ton of people who have gone to a different fertility clinic before, and their experience was kind of walk through the door, you have low AMH, some of them didn't even actually have low AMH, you need IVF. And then they're just kind of thrown into their IVF cycle. No discussion of your nutrition, your well-being, your stress level. Do you have endometriosis? Do you have adenomyosis? What position is your uterus in? What's your diet like? Do you smoke? Do you drink? How often do you ejaculate? Like nothing. It's just the IVF grinder, right? Hello, patient, money, IVF, oops, didn't work, try again. How many of you have had that experience? Oh God, like hands are shooting up in the air. So I'm very, very sorry as a representative of the fertility clinic and community. That shouldn't happen, that's horrible, I'm sorry. We need to do better for sure. But there's no question that having that holistic approach will improve your success. And anyone that tells you it doesn't matter, endo doesn't matter, nutrition doesn't matter, the vitamins don't matter, is not reading the science. I mean, it's right there, right? So there's no question that this stuff is important. Yeah. I'd be happy to be part of the research study, though, that lets me eat junk and then test my fertility. I'd be all for that. Any chocolate or ice cream diet, I am in there. So anti-inflammatory and micronutrition or micronutrient-focused diets are important. These can improve your menstrual regularity, embryo quality, even your live birth rates, and sperm quality as well. You want healthy fats, don't eat a lot of junk food. Things like bananas, avocados, these are gonna have healthy fats in them for you. Less processed foods. I know loads of people that just cut out processed foods and drop tons of weight simply by taking that one step. Adequate micronutrients, so your folate, your vitamin D, your irons, these are all really important. Your antioxidants are crucial, especially when you're stressed. Stress and stress hormones increase the level of reactive oxygen species. Most vitamins are antioxidants. You actually need those antioxidants to bind up those reactive oxygen species, which literally run around damaging DNA in your body. That's how you get cancer, that's how you get crappy egg quality, it's definitely how you get bad sperm quality. It's directly related to an increased risk of miscarriage. So these things are really critical for pretty much everybody going through this journey. Lifestyle and behavioral modifications. So I kind of harp on this a lot. If you're smoking, you're looking at an 80% decrease in success. Marijuana is the same, except it has huge neurodevelopmental outcome issues for the baby. Nicotine smoking increases your child's risk of developing cancer and heart disease when it's an adult. It's about a 400% increase in your risk of miscarriage. Alcohol is a disaster. For all those of you that drink, please stop. It's horrible for you. It's a class 1 carcinogen known to cause 7 different types of cancer, probably 5 more. We know that it's a cellular toxin, and we know that it does an enormous amount of damage to the DNA of the sperm and the eggs. I always like to put this into particular perspective because this one's really helpful. During the pandemic, everybody was dousing themselves with hand sanitizer, right? Come home, hand sanitizer, go to work, hand sanitizer. Come into contact with anybody, hand sanitizer. We use that because hand sanitizer kills everything it comes into contact with, bacteria, viruses, whatever. You see it on the label, 99.9% effective. How does it do that? Well, it's pretty much all alcohol. So when you put it on you, it kills everything it comes into contact with. What do you think happens when you put it in you? It just kills you from the inside. So alcohol's a disaster. Don't drink. It's terrible for your overall health, but it's particularly horrific for fertility. Briefly on mitochondrial replacement therapy, we know that the mitochondria age over time and they become less able to supply the eggs with the energy that are required. Now, some people may not know this, but all the mitochondria that you have in your body comes from the woman, from the mom. Men don't have mitochondrial contribution to embryos. It's all coming from the woman. So you need strong mitochondria to have a good embryo. So for those who are aging or have poor egg quality, one of the ideas has been, why don't we take mitochondria from a healthy woman's eggs and put them into the other woman's eggs and you kind of have these 3-person babies. The alternative is to take the nucleus from the patient with the not great eggs and put the nucleus into a donor egg that has had the nucleus taken out. So these are basically 3-person babies. You've got 2 women involved and then a sperm source. It's actually legal in the UK. There was sort of a version of this that we tried in Canada many years ago called Augment. It was a disaster. It totally didn't work. The company came out and made all this hype, and I think they generated like $1 billion of investment, and within about 6 months, everybody realized it was useless and it tanked and the company folded. So we're not there yet, but there are babies being born from this technology in the UK. I think at the last count it was 19. So there are babies that are coming from this. It's not like the holy grail, but it does work. Excuse me, and there are, advancements in this field that are targeting or at least focusing on making this a real option for people. So essentially, the preclinical UK studies showed it was safe because people were worried, like, are we going to have these monster babies from this? You don't. You get normally developed babies from this. And so it's actually led to the clinical application of this process. And like I said, you are getting babies being born. And the other reason we use this is that there are mitochondrial DNA-related diseases, and they are devastating, pretty much universally fatal. And so you can actually replace the mitochondrial cells, and by doing that, you can actually get rid of these diseases, which allows those people to have a chance when they otherwise wouldn't. Robots. So I'm just going to play this video because this is really cool. So this is a company from Mexico called Conceivable Life Sciences. Maybe just turn down the volume. I don't even need the volume, but this is ICSI, where we inject the sperm into the eggs. So this is something that takes embryologists years to master. They've actually created a machine that'll replace the embryologist. So this robot is taking a dish of sperm under one microscope, and then it's going to put a dish of eggs under the other one. And then using that AI technology I was telling you about earlier, it'll map out which sperm is best, which this company also has developed technology for. It'll pick up that sperm and do the injection into the egg with exactly the same outcome, safety, security, everything as a top-notch embryologist. They're getting over 70% fertilization success, which is generally considered a good success rate for anyone doing ICSI. So here's where they're picking the sperm. You can see it's actually highlighted which sperm is good with that little green dot. And so it's going to go pick that up. So they suck the sperm up into this catheter. You have to immobilize the sperm. And then you take the needle and you stick it into the egg. There comes the sperm. Right when it's at the tip, you plunge into the egg and you inject it. The sperm's gone in, and now you're done. All done by a robot, no human required. So for obvious reasons, I have not shown this to my lab because they're all gonna run screaming, but this is our future. And I wanna touch on this for a minute because this is important. Right now, globally, only 2% of the number of people that need to access IVF actually have access to it, which means we are missing 98% of the population. Even if you only wanted to, let's say, get 5 times more than we're doing now, we're gonna take care of 10% of the population, right? We make it free for everybody no matter what, so everybody can come. Drugs are included, PGT's included, you get a month off of work, we're gonna make it perfect for you. We don't have anywhere remotely close to the number of nurses, ultrasonographers, trained reception people, lab people, equipment, or doctors to do the retrievals that are necessary for that. So I would consider myself a relatively busy fertility specialist. I personally do close to about 500 egg retrievals a year. That would be considered high level. The highest I've heard of is about 750. The estimate is that we need to do 1,600 egg retrievals per year just to meet what's needed. Like, there's no way. I couldn't see any of you. I would just be doing, 10 egg retrievals a day every day. Like, it's crazy. So we need this technology in order to just be able to support the demand of what IVF actually requires. So this is up and coming. So a little bit about us, a little shameless self-promotion. So we're really dedicated to constantly improving, and we want your IVF journey to be better. We have a research team led by a guy that is so smart, I actually find it terrifying at times. I don't understand half of what he's saying. He's a brilliant PhD that works with us now and runs our genetics program, and he's developing new tests as well. So we are going to be doing this in vitro maturation protocol because I think it's a real wave of the future, and it has never been done before. No medications. It's kind of like meet you today, retrieve you tomorrow, put the eggs in the dish, see if they work. So this is really exciting stuff for us, where we might be able to change the way things are done and revolutionize the fertility world. We do work very closely for a holistic approach. I never want you to leave our program saying, that was like everybody else. Pretty much every single consult I do, people will tell us they got more information in 30 minutes or 45 minutes of time with me than they did in the last 7 years of their fertility journey. And that's because I want to explain every single detail to you. I want you to know about it. Tarek and I on our show pretty much tell people all of our secrets on a weekly basis because we want you to do better. Even our endometriosis protocol, it's on our YouTube channel. It's free for everyone to access. We do want you to subscribe, like, and comment though. He'd kill me if I didn't say that. So we really want to collaborate with experts who know their stuff. We had a great podcast with endo.fertility.dietitian Cindy Dabrowska. Good God, she's a nutritionist, but she's like one of the smartest people I've ever met. She knows everything about microbiome, about nutrition, about what to eat, how to manage your health. And in particular, she focuses on endometriosis. So there are great people out there that can help you. I think individualized care is really the future. That's going to be what we get in 2035. We have a dedicated protocol for endometriosis. So again, shameless self-promotion. If you go to our YouTube channel, it's that first video. If you type in endo protocol, we tell you what to do to make it better. I get a response from people all across the world, at least several times a week, who say, we had 9 embryo transfers, none of them worked, we used your protocol, now I'm 23 weeks pregnant, or had her baby, and they send me pictures of their baby. And I've never seen these people in my entire life. Never heard of them, never seen them, never spoke to them. They just followed the protocol. Because we're doing what's more advanced and what's necessary to change your success. Genetic-based response predictions. So we know now that if you analyze people's FSH receptors, because there's different types of receptors, you can actually tell them which gonadotropin to use. Should you use Puragon? Should you use Recavel? Should you use Gonal-F? Should you use Menopur? You can actually tell them which one they're going to do better with by testing which FSH receptor they have. No one's doing that yet, but it's actually available and it's possible. So this is another way for us to kind of improve the outcomes for people. There is a microscope coming, hopefully, from Israel. We're working on Health Canada approval, which can actually track the motion of the sperm in 3D. That's actually 3D capture of sperm motion. So they actually spiral as they swim. I have no idea why, but they do. And this microscope actually can tell you whether the sperm have high DNA fragmentation as well before you use them, which is currently not available on any other method or platform. You can test sperm for DNA integrity, but then you can't use them. With this new microscope, you actually can. So this is going to be fascinating stuff that's coming around the corner as well. We just need to talk to Health Canada and get them to agree. There are tests coming. I want to talk about this as well. But there are tests and then there are tests, okay? So endometriosis, numerous companies are working on tests to diagnose whether or not you have endo. Many of you will have heard of Matthew Leonardi's SUGO program in Hamilton. Matt's a brilliant guy doing work on what findings on ultrasound and MRI predict endometriosis. There are blood tests being developed. There was one in Canada briefly, but It's on shutdown until they provide research. There are several in the UK, and I think there's one in the US right now as well. Plus, many of you have probably heard of Receptiva. Yeah. So right now, none of those work. So don't waste your money. There is no diagnostic test for endometriosis. Even Matt's Sugo ultrasound has at most predictive value of about 80–86%. So you're still going to miss some cases. So I support that because it avoids surgery, but don't spend money on testing because none of the expensive tests that you pay for are diagnostic yet. You need laparoscopy if you want to know if you have endo. Endometrial receptivity, the ability of the embryo to stick to the endometrium, that's something that's up and coming as well. There was one test available. It's not beneficial. And that test actually reduces your success rate by 13%. I won't mention names because I don't want to get in any trouble, but there is no adequate endometrial receptivity test right now. None of them actually work. IVF success predictors, how good are we? I actually want to show you this. So this was an article we reviewed on our show 2 weeks ago? 2 or 3 weeks ago, right? 2? Yeah. So this is called the Fortune IVF app, for free, available on the Apple Store. Okay, it's based on a research study that used AI to model what your chances of developing at least one euploid genetically normal embryo was based on a bunch of characteristics that they analyzed using AI. So this is me actually using the app, so just watch this. So you click the button, you enter your AMH. So I just picked something low, 0.5, and this is nanograms per mil, which in Canadian units would be about 2.5, 3. Your AFC is going to be about 4, which would fit that AMH level. The woman's age is, let's say, 42, because that's probably what we'd see with that AMH level. And you've got a handsome devil of a partner, and he's roughly the same age. Okay? You're maybe average height. I just randomly picked numbers, maybe a little bit taller for a lady, and your weight slightly above average. Okay, nothing terrible. So I chose 145 pounds. Pretty reasonable for someone that's 165. So you click the button, and this will tell you that over 80% of patients who do IVF will not develop a euploid embryo. More importantly, if you're in the very poor category with this app, it showed that you have a 0% chance of success. Don't try. You will not get a euploid embryo. So this is very powerful, and this is for free. So I'm going to be using this from now on with every single patient because, like I said, we need truth and transparency, and this is it. This is truth and transparency on your phone. You don't even need the doctor. You have everything you need to know, are you going to be successful or not? And again, I have nothing to do with this company. So very, very interesting, powerful data, because this is a game changer for everyone. Web and AI-based fertility, doctors, coaches, diagnostic tools, this is up and coming. I am the medical director for Mystoria, and they're here today. So basically, this is a web-based platform to help improve your fertility journey. So this is awesome. This is basically everything you needed from your fertility clinic that you're not getting. And this is the wave of the future, because when you can't get it from your clinic, you still need those resources and support to do better. This is how you get it. So you basically pay a subscription fee, you get a team of people and computers that are going to help you through your journey. There are also other companies doing this as well, some that are very, very sophisticated. One in particular that I am doing consultation for, which once I looked at, I said, I am going to be out of a job once this goes live, because it is extraordinarily sophisticated in a diagnostic application. It covers microbiome testing, nutrition, vitamins, your stress levels, whether you do yoga. It'll tell you about your immune system. It'll literally target every single problem you have, tell you how to fix it, who to see, what to take, in a way that I would say over 95% of doctors aren't even capable of coming close to. And I pride myself on knowing all of that stuff. I'm very proud that they selected me to kind of consult for them, but this is actually smarter than I am. And so sooner or later, we're going to be looking at a world again where you guys are going to be talking to computers to some extent, or using computers, because I'm going to be busy doing egg retrievals until they figure out how to get a robot to do that as well. One more thing about social media. Some of you may have seen this, and we don't need any volume on this if you want to just turn off the volume. I think it's going to show us an ad first for something. Sorry about that. This has nothing to do with fertility. So what's coming is these, you see these all the time on YouTube, right? So, or Instagram. So there's always these like robots that are carrying babies. A couple of months ago over the summertime, they had that thing that looked like the Matrix with all the little incubators in a room, and they said, you know, we're going to have surrogacy pods where you plug the baby in. For those of you that are wondering, this is all total BS, right? That's all AI generated. There aren't robots that look exactly like women that are rubbing their tummies anywhere. And while China claims that they've actually successfully created an artificial womb, so far, no one has successfully done this in babies. They've had sheep that they can get about halfway through the gestation, but no one's actually been able to take it all the way. Nowhere more in my life did I realize how complex biology is till I was at the University of Michigan in undergrad and I took a cellular and molecular biology course. There are billions of cellular processes going on all the time. There is no way as human beings, even with the AI technology that's available, that we can figure all of that out enough that we're going to have robots carrying babies or have surrogacy pods. We're not headed towards the Matrix anytime soon. Maybe way, way, way into the future, but this is a hoax. Okay, it's not real. Any questions? Yeah.
Regarding azoospermia, specifically germ cell aplasia, if I'm pronouncing that correctly, is there any reversal of that or hope to change that, or is micro teas or micro tests the only potential solution?
Yeah. So the question is regarding azoospermia, specifically one subtype, is there hope without having to dive into the testicle to do a biopsy? And the answer is there's lots of hope. There was a recent study that we're going to try and duplicate where they gave guys isotretinoin, which is Accutane, the acne medication, and after 6 months, 80% of those guys started producing sperm. People are trying PRP, although it's kind of iffy as to whether or not it works. So there is hope, but we're not fully there yet. But Accutane, aside from having a lot of negative side effects on drying out your mucous membranes, is pretty harmless. You should talk to your doctor about that, or me. Yeah. Any other questions? Yeah, you're gonna have to yell in the back because I can't hear up here. Oh, do we have a mic? Oh, hang on 1 second. Even better.
Hi there.
Hey.
So on the application that you showed where you enter your diagnostic results and your AMH levels,
Yeah.
it tells the patient that there's a 0% chance of getting euploid through
Right.
IVF. Is that accurate, and is there like more information that can be shared with patients? Like is that safe to be showing to patients that don't even try?
Yeah, it's safe. If you look at the research study, which we reviewed, is it up on the YouTube channel? It's in the live session? Okay, so if you look at our YouTube channel, you'll see where we actually reviewed the article and I showed people the data. So first they ran the data using the AI, and then they actually applied it in a clinical setting. You have a 0% chance of getting a euploid embryo in the very poor group. So yeah, it's real.
Data back. Cool. All right.
Yeah. Yes. Wait till she brings you the mic. Marissa's going to get her exercise today.
When you were speaking about low dose protocols,
High dose protocols? Yeah. Oh, low dose protocols. Yeah.
what kind and what energy dose would that be?
So typically when we talk about low dose, we're talking about staying under 150. That's your kind of max threshold. So when you're talking like mini stim, we're talking about a max of 150 units.
Are you adding Medicare and Megalab, or are you taking 150 Megalab?
That's up to your physician. I will advocate for a mixture in most cases because there's a large British study from many years ago which showed that if you mixed a urinary and a recombinant product together, you had a higher rate of genetically normal embryos. And based on the fact that our lab actually has one of the highest rate of genetically normal embryos in the country, I think it works. But as I showed you, it actually depends, now we know, on your receptor subtype. So the likelihood is high that the British study was showing that because you're kind of catching everybody. Whereas if you actually test your receptors first, you can actually know which one to take.
And actually, that's my second question. Are you doing that testing?
Not yet. I probably will very soon, but we're not there yet. I want to probably do it like in our genetics lab. So my PhD guy will kill me if I add another thing for him to do right now, but we'll probably be doing that very soon.
Okay. And just one clarification.
Yeah.
When you say 150, is that 150 dose of Gonal plus Medicare?
No, total. Total. Yeah. So let's say you want to use a mix, you would do 75-75. Yeah. Was this helpful? Yeah?
Hi. Could you elaborate a little bit more on silent endometriosis, and if there are no symptoms, how can one know about it and how we can avoid suspect?
Endo? Sure. Yeah. So about 40% of women, 40 to 45% of women with endometriosis have no symptoms. So how can you detect it? You can't. You have to have laparoscopy. But I'm going to flip that around to give you a much more relevant statistic. How many of you were diagnosed and are willing to share with unexplained infertility? Okay, fair number. So between 44 to 90% of you will have endometriosis. So when they actually analyzed the data by operating on these patients, somewhere between 44 and 90%, there's different studies and it's a big range, actually have underlying endo. So you're not actually unexplained until you've had surgery. So a substantial number of patients struggling with infertility do have underlying endo or adeno. Now, the sequence of events that follows is complicated. If you're in Ontario or you're from Canada, getting surgery is virtually impossible. And I'm an expert minimally invasive surgeon. I do stage 4 endo, but if I could get anesthetist to work, it would be great, but I can't. They don't want to work. So we have 0 OR time, and my patients are waiting 6 months, a year, just to get into the operating room. So the timeline of your treatment is complicated, and no one has actually shown this yet, but I am 100% convinced that endo patients have diminished ovarian reserve tendencies as well. So it's not just that they are suffering from endo, their ovarian reserve declines more rapidly than someone that does not have endo. And we know that if you have endo, you have a lower ovarian reserve, but I think the trajectory of that reserve is much steeper than in a woman that doesn't have endo. So you don't have the time to wait for the surgery, which is where it gets really complicated. So we need the government to wake up and say, if we're going to help patients with infertility, it's not just IVF. You need to provide us with the resources. We need to train more anesthetists, or for God's sakes, bring in CRNAs so they can take care of cases for us. We need OR time, we need space. Yeah, and then there's financial things as well, right? the vast majority of fertility specialists don't do surgery anymore because it doesn't pay. So I hemorrhage money when I go to the OR, but I do it because the patients need it. But I'm losing money. My office screams at me, they want me to quit, but it's good for the patients, so that's why I do it. But you can't, like most fertility specialists, don't operate anymore. Yeah.
Do you know of any clinics in the province that are providing the FSH receptor test?
Not that I'm aware of. I don't know anyone that's doing it. Yeah. Anyone anywhere? I am not aware, but I'm happy to look it up for you and find out. Probably a useful thing. I'll contact Adam, our guy, and ask him how long it'll take him to do it. He is going to kill me, so if you see a body in the corner somewhere, it's me. We need to be able to offer it. Having said that, there are issues with that as well. So as an example, the only urinary product available right now is Menopur. Menopur is intentionally contaminated with HCG, has 13 units, I think, of HCG per vial, which is great. It actually is really good for egg quality. I support it. It's a great product. However, too much Menopur and you actually cause the small eggs not to grow. So there's a limit to where this will work, right? And that's why even if someone had a receptor mutation that said you should use this, because it's a contaminated product, we don't have that many options. And so you can't use 300, well, you can. I don't recommend people use 300 units of Menopur because you're compromising the outcome. Yeah, great question. Any other questions? Yeah.
Thinking of the endo protocol and just diagnosis, do you ever recommend people to use the endo protocol without getting an actual formal diagnosis for endo via?
Can I just hide now? So the question is, do I ever tell people to use our horribly mean to women endo protocol without an endo diagnosis? Let me briefly tell you what our endo protocol is. So it's 3 months of hardcore suppression. That's Lupron and letrozole. Lupron alone is useless, by the way. Don't ever do that. As part of that, you're on a whole bunch of supplements which are very good for endo: NAC, curcumin, resveratrol, ALA, coenzyme Q10, and then a whole bunch of other basics like fish oils, prenatal vitamins, vitamin D, and so on. And then on top of that, you have to use high-dose progesterone, which is injectable and vaginal, because all endo-adeno patients are progesterone resistant. And you need to measure your levels to target a certain threshold, which is way higher than most clinics are used to. And then you need an immune protocol, because we know that endo-adeno patients have severe immune dysregulation. So we use intralipid steroids, tacrolimus, but there's a variety of approaches. That's what we do. So do I recommend people do that if they don't know that they have endo? It's really, really rough on women's bodies, on relationships, on their minds. Like, we're talking about you being healthy, lovely, normal, natural you, to you being menopausal you in 1 week's time. And menopausal you can sometimes have homicidal tendencies. So it's like not a nice thing to do to a lady. Yeah, exactly. I usually tell the guys, don't worry, I have a spare bedroom. So it's not an easy thing for a relationship or for the patient to endure. So would I recommend it? Sure. But is it a friendly thing to do to a lady without a diagnosis? No. No. It's pretty rough. Yeah. That would be a great case for go see Dr. Leonardi, let him do the Sugo. Let's at least get a guess.
Have you heard of ovarian stem cell injections? And
Yeah.
if so, where is your BS level on that?
My BSometer. So I think, although I'm not sure, that I was the first in Canada to try ovarian PRP. Ovarian stem cell treatment is not allowed yet here. Ovarian PRP is because people are injecting PRP everywhere. Okay, so originally this data came out of Greece. There was some clinic that fired PRP into a woman's ovaries, and half the universe flooded to Greece because this clinic published it and said, we found the Holy Grail. Okay, so that was total BS. They didn't find the Holy Grail. Everyone that went there failed. So then Richard Scott's group, Richard Scott is one of the gods of IVF. He's a person who is smarter by orders of magnitude than anyone that I know. His group did research and initially had, I forget, about 230 patients or 250 patients, and then they repeated the study again a little while later and they had over 500 patients. And what they showed was in these like essentially menopausal women, 13% of them went on to have a baby, which was like amazing, right? So then 2 randomized controlled trials were done. And in one trial, they showed that you made more eggs, but you did not have an improvement in live birth. And in the other trial, they showed that there was 0 benefit whatsoever. Now, there's a guy in the States who is a strong advocate for this and has something called the Ovarian Rejuvenation Clinic or something like that. And he's using all sorts of weird stuff. And he says, no, everybody else is doing it wrong. But if you look up his results on SART, which is the American registry, they're no better than anybody else's. So what I typically tell people, and this is not research-based, so I want to say that categorically, is that if you're young and your ovaries have failed or are in the diminished ovarian reserve category, you may benefit from ovarian PRP. It's a may. And I've seen it, and that's why I say that. If you're, like I get calls from women all across Canada pretty much every day. I'm 48, I want to come and do ovarian PRP. That's a waste of time completely. So the ovarian, like that app is great, but Tarek and I basically created a video 5 years ago, called Embryo Math. It's on our YouTube, it's one of our popular videos. So it tells you exactly how to calculate how many cycles of IVF you're going to need based on currently available data. At 48, you need somewhere around 40 eggs to produce one genetically normal embryo. And that one normal embryo at 48 probably has about a 25% chance of becoming a live birth, just because of energy efficiency and mitochondrial damage and so on. So how many eggs are you going to produce at 48? 2, if you're lucky, 3 maybe, unless you're like Wonder Woman and have some sort of freakishly high AMH. But the average 48-year-old is going to make 2 or 3 eggs. So now I fire ahead and I do PRP for you. How many eggs are you going to make now? 4. Maybe you get really lucky, you make 5. You still need 8 rounds of IVF for a 25% chance. You're bankrupt, you're sore as hell, you've probably undergone some degree of risk, and I've got 0 chance of telling you it's going to work. So I think it works in younger women, but I don't think it works as well in older women. Yeah, just because of the math. And that, I always tell those patients the math isn't mathing. Another great question, thank you. Any other questions? Thank you for having me. We have a booth up at the front, and if you have any questions or you want to meet me or my team, please don't hesitate. If you have questions for Dr. T here, you can ask him as well, anything social media related. Please be careful. I think the one thing I would leave you with is be careful in your fertility journey. Not everything you hear, whether it's from the doctor or social media, is necessarily what's best for you. Take everything with not just 1 grain of salt, but many grains of salt. Research everything to death, and explore everything before you jump in. The most important message I can leave you with is that everyone feels rushed in infertility, right? How many people feel like they're under pressure? Yeah, pretty much everybody feels